Hello, I'm Richard LeBlanc. I'm a hematologist and medical oncologist in Montreal. I'm working at the Maisonneuve-Rosemont Hospital. The title of the poster is the impact of Bortezomib used in consolidation after allogeneic stem cell transplant. So we know that myeloma is a morbid disease, is a lethal disease with a median life expectancy around 5 years. And for patients with poor prognosis, cytogenetic, and other biologic factors, the median survival is even lower. We have a good experience with allogeneic stem cell transplant used after autologous stem cell transplant called Tandem, Auto, and Allo transplant with a long median follow-up of 8.8 years and the median PFS at 10 years reached 41%. So meaning that 41% of patients are still alive at 10 years without any sign of active disease. So we want to build on that good experience, and the two main obstacles of this procedure is the fact that 50% of myeloma patients still relapse after the allogeneic stem cell transplant, and we have a high incidence of chronic GVHD that reach 80% of patients. So we want to improve these results, and we have access to Bortezomib, proteasome inhibitor that can decrease the incidence of relapse of myeloma patients and has a positive impact on chronic GVHD that can prevent and even treat chronic GVHD. So the design of the study is after induction treatment and after standard autologous stem cell transplant for eligible patients to propose an allogeneic stem cell transplant, and after a consolidation using Bortezomib for a year of treatment. The eligibility criteria are mostly based on the risk of the patient. We select high-risk population based on their ISS 3 or based on their poor cytogenetic risk, such as deletion 17p, translocation 414, 1416, 1420, and even chromosome 1 abnormalities, or even patients with plasma cell leukemia at time of diagnosis. We have also an inclusion criteria based on the age only, because these are those patients who lose the most year of good quality of life. So we have treated 40 patients, and 39 patients are evaluable for the result. And what we can see from the trial is the response rate improved with time after the induction, autologous stem cell transplant, allogeneic stem cell transplant, and Bortezomib consolidation, with a high incidence of immunophenotypic complete response, defined as a stringent complete response, followed and with a negative MRD for 2 consecutive MRD. So it's a strict definition of immunophenotypic complete response, and this rate reached 20% after the autologous stem cell transplant, 26% after the allogeneic stem cell transplant, but reached 63% after Bortezomib treatment, so a very high depth of response. For the primary endpoint, which is the progression-free survival at 2 years, we have a median follow-up of 2 years now. And the median progression-free survival reached 34 months, with a 2-year progression-free survival very interesting for this type of patient with high risk genetic. The overall survival at 2 years was 91%. Concerning the toxicity, the treatment was pretty safe. Concerning the Bortezomib consolidation, there is no new signal concerning Bortezomib. We have some patients, 2 patients out of 39, who increased their manifestation of peripheral neuropathy, but we noticed the same toxicity as what we usually see with allogeneic stem cell transplant, nothing new. In terms of chronic GVHD, what we can see is that the risk is much lower than what we had in the past. We did a comparison with a recent historical control cohort showing that the risk of moderate to severe chronic GVHD and severe chronic GVHD was much lower with the use of Bortezomib. So in summary, Bortezomib used in consolidation after allogeneic stem cell transplantation is a safe treatment, it's well tolerated, it can improve significantly the response rate and the depth of response, and it increases probably the PFS. We don't have a control group in this trial, but certainly it decreases the chronic GVH incidence and the severity. So we expect to see some cure with this procedure. Thank you.